So, Professor Deanfield, we have lecture, a very interesting presentation of you in this room in Sinaia. You have mentioned the risk factors we were talking about when we start this interview. What are the new approaches you have mentioned in preventing and fighting with this?
So we're in a unique
factors.
situation with cardiovascular disease to really tackle prevention in the population. And the reason for that is we understand the causal structure for coronary disease better than almost any other disease. We know the risk factors that account for most of the heart attacks and strokes in later life. We also know that we're exposed to those risk factors for many years before the clinical disease begins to emerge. We also have ways to reduce that risk exposure, either by drugs or by change in behavior, and that's what I think we need to talk about. And when we do that, we know that we invest in our arteries and we prevent future problems in later life. So this is a fantastic situation to take this most important disease, cardiovascular disease, and really make an impact on the population's health.
And regarding the United Kingdom experience in fighting these risk factors with this new approach, what can you tell us about?
Well, there are major risk factors for cardiovascular disease. Smoking, cholesterol, blood pressure, diabetes are the major ones. And we know now that if we can target those risk factors and reduce them, we will get clinical benefit. Now, the traditional approach that doctors have taken have been perhaps rather amateur. We've lectured our patients and we tell them not to do something and we hope that they listen to us and don't do it. But actually, we can be more subtle here and try and reduce exposure by reducing the harmful exposures over a long time, starting early. So we call that a harm reduction strategy. And for example, if we were to take food as an example, we don't tell people to stop eating if food is bad for you. We tell them to change their eating, change the amount they eat, what they eat, and the like. And that is a stepwise reduction in the effects, the bad effects that overweight and obesity can have on the future. Tobacco is a similar example. We know that combustible cigarette smoking is really bad for us for multiple diseases, including cardiovascular disease. And if we can reduce combustible smoking, we can make a real difference to people's health. Now, what we've learned, not just in the UK, but around the world, is that the earlier we start, the better the outcome. So it's an investment opportunity. And small changes done for a long time early make a big difference to future risks. So this applies to the different risk factors. It's a sort of harm reduction strategy.
What should we consider when we evaluate the effectiveness and impact on public health of these policies?
Well, clearly we would like to reduce mortality and the damage that these diseases cause in the population, but we can't just look at early interventions in terms of risk of death, heart attacks and the like. We have to look at the impact on markers that we know are associated with the development of disease. For example, we target blood pressure, we target cholesterol, and those sort of things, because we know that if they're elevated, they lead to disease in later life. So we have to use some of these intermediate measures to allow us to evaluate the impact of our early interventions on future risk.
But regarding smoke control, how can we evaluate the effectiveness of public policies?
So that's a really good point. Smoking is a very important risk factor because combustible smoking is really bad. Now, when we banned combustible smoking in public places, we saw very quickly an effect on cardiovascular outcome. Within months, the amount of patients coming to the hospital with new cardiovascular events, heart attacks and the like, went down when this was done. So quite clearly, we have evidence that reducing exposure to combustible smoke produces a very immediate return in terms of outcomes. Now, we know that there are steps that we can take to reduce exposure to tobacco-related products that are much healthier than combustible smoking. And if we could introduce those into our prevention strategy in a stepwise way and reduce combustible smoking as a result, we would anticipate to get the same benefit. Now, clearly, we can't do a randomized trial. It would be unethical to do a trial of smoking versus other alternatives. So we can look at population data to begin to see how, when you do change the way people are exposed to tobacco-related products or even just nicotine, we see that as we take away combustible smoking, the benefit is very substantial in the population. In Sweden, for example, a lot of people have switched away from combustible smoking to oral nicotine. And when that was done in the population, in the men particularly, the tobacco-related harm went down dramatically from the highest in Europe to one of the lowest.
Well, give us some example of what stakeholders are involved in these policies, and how can each one of them contribute to such an endeavor, let's say?
Yeah, I think the endeavor to reduce harm from risk factor exposure has to involve multiple different stakeholders. The medical profession has to provide the evidence and has to champion this idea that early interventions to reduce risk, sustained early, produce that long-term gain. The public health environment has to make it conducive to do that. Banning smoking in public places was a very good example for that. But changing food would be another example, a way in which collaboration with public health delivery could enable a better result. And of course, governments have to embrace this idea, because at the end of the day, reducing exposure to risk factors in this way will translate to a health benefit and also a wealth benefit in terms of the health of the population.
And the public, we are discussing about the empowerment of people regarding their health.
Yes. So the public, of course, have to be engaged. We haven't been very good at communicating risk and benefit to the public. We communicate risk, we tell them not to do things, and patients often, and people often go away, more or less engaged with that. But I think when we inform people differently about not just their risk, but also their benefit that they can have personally, and enable them to do this, I think we will see potentially a much better impact of early intervention on future disease prevention.
But are the doctors informed? Regarding the risk, you have mentioned that eliminating smoke is a great benefit. Are the doctors aware of that?
Yes.
The studies exist, a lot of studies, but do they know?
No, I think doctors are well aware that combustible cigarette smoking is very bad. And there's no doubt that everyone would agree that stopping combustible smoking in people who smoke already is a laudable aim, but also preventing young people from ever taking up combustible smoking is absolutely vital. So I think there's general agreement on that. What people aren't necessarily aware of is the potential for reducing the harm that people have from combustible smoking, not by just telling them to stop combustible smoking and not giving them an alternative, but by providing safer alternatives to take them down a journey to reduce their risk. And they include vaping, they include oral nicotine products and the like, which are clearly much less harmful than combustible cigarette smoking. So these become potentially valuable steps to reduce the harmful impact that smoking has in the population and take people down that risk journey.
But are there studies that could confirm that?
There are clearly studies that show that oral nicotine and vaping is less harmful for multiple diseases, cancer, cardiovascular disease and the like. Oral nicotine, for example, is not a carcinogen, and nor is it something that directly causes heart attacks or strokes. So these are much safer alternatives to combustible smoking, and people are not necessarily fully aware of that.
Heating tobacco is safe.
Heating tobacco is safer than burning tobacco. Clearly, the worst thing you can do is to consume a cigarette with burning tobacco. That's where the carcinogens come from. That's where the adverse effects of cigarette smoking is most clear. So avoiding or reducing combustible smoking is the absolute aim of all strategies.
You have mentioned Sweden. Which other countries could you give us, for example? An example.
So other countries are debating and adopting policies to do this. No one has
Japan,
as clear data.
for example.
Yes, Japan has data on this as well. The UK has embraced vaping as a strategy to reduce combustible cigarette smoking as a step down. So these alternative approaches are getting into national policies and clearly have to be viewed as a stepwise way of reducing the harmful effects of smoking.
Thank you.
Similarly, we're doing the same now. I think we're going to be addressing food and eating in a similar way.
Less salt, for example, less calories.
Less salt, less calories, less processed food. All of these things are steps in the direction to reduce the harmful effects that we now see are associated with obesity, the development of diabetes and associated diseases. So very similar approaches in terms of a harm reduction strategy that can be taken for food products as well.
And we are not making enough physical efforts. How can you deal with that?
So you're right that there are other lifestyle changes that we could all adopt that would make us healthier and hopefully delay or even prevent future diseases. There are public recommendations to increase physical activity, and everyone would embrace those. So we encourage people to take a certain number of steps a day, to be much more active in their life, and there are different ways in which we could do that. Now, individuals need to make those choices, but also the environment needs to change to make it possible to do that more easily. So I think these are very important changes in our cities in the future, and also in the way in which we transport ourselves around the place. Most importantly, though, I think we have to take the next generation, the children, and educate them about their potential to maintain their health better. We've not been very good at that in terms of the school curriculum and about the way we message young people and explain to them the benefit they can get in terms of their future from being healthier from an early age.
What new strategies or approaches have emerged? How best to do this prevention?
Well, the
how
medical
to integrate it in medical
So doctors, we as doctors, have not been particularly good at communicating to the public about the opportunities they have to manage their health better. So we have to start thinking about informing the public about what they can be doing and then helping them to do it, empowering them to do that. Now the big difference is it's not just you mustn't do this, you mustn't do that, these binary decisions. Little things done early and sustained produce an incremental benefit. So this idea of harm reduction by making changes early and sustaining them throughout life is gaining importance. And we realize it's like investing in your arteries in the same way as we would do for our finances. You wouldn't think about starting to save for your retirement when you were 64. You would think about doing something about your pension planning earlier. We have to think about health that way, do little things and sustain them early to get the compound interest and the benefit.
So the ultimate goal remains the elimination of risk factors. But practice has shown that gradual approaches, as you have mentioned, are necessary. So can you give us more details about this, about the implementation of these approaches?
Yes.
Modern.
So let's take two risk factors as an example. Smoking and how we eat and nutrition and overweight. These are two very important risk factors for the population. So in smoking, we've actually been very successful. The first thing, obviously, is to avoid a bad risk factor in the first place. So a child born today should be encouraged as far as possible never to be exposed to tobacco and related products. That's a given. However, there are lots of people who still smoke and who cannot, for one reason, just stop smoking. So for them, we've got to be able to develop alternative strategies that allow them to be exposed to nicotine, but in a much less harmful way. And that's happened with a range of products that actually reduce the risk of smoking-related diseases. That's a nice example of harm reduction. Another one, similarly, would be our approach to food and to eating. So again, we can't stop eating. We have a risk factor associated with our diet and the way we eat and the way we live. But we can mitigate that risk by improving the quality of food, making sure we don't become obese, and actually now with new drugs, actually helping us avoid obesity and manage its consequences. So all of these things are good examples of a graded approach to harm reduction to reduce exposure to risk factors, at the same time obviously trying to make young people avoid them in the first place.
So these modern strategies are age-related?
They're not age-related strategies, but they are
or
strategies
group-related
that are best
regarding individual
yes.
risk.
Yes. So I think when we're looking at risk, we know as a principle that the earlier you start and the longer you sustain that benefit, the better the benefit will be. And that's again like your saving account. It's like your finances. But they're not something we should just give out as a general message to the public. We should try to target those things for individuals. So personalized prevention, what works best for you, is an important way of empowering people to understand their own potential for benefit. I think understanding risk, but also understanding what works for you is going to be a very important part of the sustainability of that message.
And in United Kingdom, what's the experience of United Kingdom regarding harm reduction?
So people in the United Kingdom are now become very aware that we have to shift away from just disease management towards a whole approach to population health. So the government is particularly interested in this now, in developing long-term strategies to do three things, I would argue. Inform the public of their risk and their opportunity, empower them to do it, and perhaps in the future start to reward them for achieving certain targets. And I think if we can do those three things in a scalable way, then we'll have a real chance to alter the trajectory to disease. And of course, that's going to require digital technology, it's going to require a new way of communicating and helping the public, not necessarily done within the traditional illness environment, but done perhaps in parallel to that illness environment.
And when we are evaluating the effectiveness of and the impact of a health public policy, what should be considered?
Well, of course, there are some immediate...
So give us some example related to cardiovascular disease.
Yes.
You.
So, of course, the impact on cardiovascular disease can be measured in terms of the clinical problems in later life. For example, when the smoking in public places ban was initiated in Scotland, within months, the number of patients appearing in the hospitals with acute heart attacks had been reduced. So there's no question that you can look very rapidly in some situations at benefit from a risk factor reduction strategy. Of course, the other way to do that is to look at intermediate measures. For example, we can look at the impact on blood pressure. We can look at the impact on weight, on exercise behavior, all these intermediate factors, cholesterol level, of course, all of which we know are causal for future disease.